I do have a question. I just spoke with Ms. Huffman about your boards out here. Do you all want your boards that you made? You want your board? Take it. If not, I'm going to take them down and I will just put them in my office because we can only leave them up for a week, okay? But you did do a great job on them. Better than the last version. Okay? So I will give you that.
Thank you.
I give credit where credit is due. You did do a good job on them. Okay. So medication depends on the type of seizure that they're having. Medications may include Ativan, Valium, and Dilantin. Okay? That chart 39.2 is actually probably from the 9th edition book. No, it is 39.2. Page 864, 39.2. Page 64. 10th edition. Our surgical interventions is the VNS. Okay. I don't see many of these done. They're usually handled by medications. But just know your VNS. Okay. So nurse, when they have a seizure, you want to evaluate the blood levels of medication. Now, this is once they've already been placed on treatment, okay? One of our big ones, you can use phenytoin, valproic acid. You know, a lot of these build up in the system, or they can be too low, okay? Which can cause them to continue to have seizures. So, but any patient who has a seizure, the very first thing I do is look at their lab values, because serum electrolytes can play a role also, okay? When you're putting them on these types of medications, you need to be very careful about drug-to-drug interactions. Any medications that they are on can interact with seizure medications, okay? They have to maintain therapeutic levels in the blood. So these have to be tested, okay? Once they reach a therapeutic level, like they'll probably be tested for like 2 weeks in the beginning, for a while. Then they can go to like once every 6 months once they are therapeutic on this drug. Okay? Do not administer Coumadin with phenytoin, Dilantin. And you always want to document or report any adverse effects. The education with seizures and seizure medications is very, very important. Okay? Seizures that last more than 10 minutes can cause death, and those are our status epilepticus. And I'm not going to focus on all the seizures. I'm just going to focus not on all the types, but I am going to focus on that. Because if a seizure lasts more than 10 minutes, they can't die. And those are your status epilepticus, whatever. Once somebody has a seizure, they are then considered what? Epileptic. Can they drive? They lose their license. So many won't report that have a seizure because they don't want to lose their license.
I have a friend who is that I worked with except left it. But he didn't have seizures but like a couple times a year. He never reported them because he would be able to drive back and forth to work if he had seizures.
Yeah. People will lie about it because they don't want to lose their license. All right, so some of these medications for seizures can be expensive, so we need to always make sure they have the resources to get their medicine. They cannot miss these medications. Okay. Keeping them safe, work and home. I mean, if they're operating heavy equipment and they're have a history of seizures, that's probably not a safe environment for them, right? They cannot stop their meds once the control is achieved. They can't just abruptly stop these medications. They cannot stop them for the side effects of nausea, vomiting, diarrhea, constipation, which goes along with every medication in the world. Okay? You just give them an antiemetic to go along with it, right? A lot of these cannot be taken if you're going to have a child. They'll reevaluate and see if they can put you on a different type of medication during that time. Sometimes it's the risk versus the benefit. Your you all went over meningitis last semester, right? Pretty much. And you go over it with Dr. Sager and infections. So I'm not going over that. We're going to go to strokes. And I'm not going to go into depth of which strokes on you, but we have taken some students into the clinical setting who did not know how to recognize a stroke. Okay. And did not know how to recognize the blood pressures and things like that that go along with the person who has a stroke. So we decided to add this into our clinical setting because we do see some on PCCU. We already have this semester. And you will see them on 7 South. All right, so strokes are caused by any interruption of perfusion to any part of the brain that results in an infarct. Okay? We're all talking about squash today. There's a lot of things that happen to our squash. Right? Just like our heart. Our brain is very, very important. Stroke is a medical emergency and should be treated immediately to prevent disability, permanent disability. 20 minutes to get into a CT scan. Right? 20 minutes. If it takes whoever that is, that team or whatever, 15 to get them there, 15 minutes to get to the floor, you better go ahead and be on your way to CT scan. Types of stroke. They can be acute ischemic. That's caused by blockage of the cerebral or carotid artery, sorry, my OR is an OF, should be an OF, by either a thrombus or an embolus. And what are thrombuses and emboluses? What's different?
One's moving.
See how, wait, what? You're building on? Hemorrhagic stroke. The vessel integrity is interrupted, and bleeding occurs into the brain tissue or into the subarachnoid space. What would you assess?
People's level
LSC
consciousness.
first. I've got LSC first. Pupils. Doing neuro exam, right? All of this goes together. Neuro. Most strokes are preventable. Your ABCs, aspirin, blood pressure, cholesterol, smoking. Right? ABCs. Different meaning, but ABCs. Fast. CNC came up, or started, well, we use this at CNC, so that's where we're going on clinical. So. Face, arm, speech, and tongue. Face, arm, speech, and tongue. Called METI. I've had a patient who had a severe facial droop, slurred speech, decreased level of consciousness. Called METI. Your NIHSS stroke scale. I am NIHSS certified. I am stroke certified. Worked a lot of stroke units in my career. I keep up with my stroke certification because you can see it anywhere, anytime. So NIHSS is a scale that we use to perform an evaluation. And evaluate them. So take a look at that. Last thing I want to talk to you about is blood pressure in somebody who has a stroke. And then we're done for the day. I did make an ABG PowerPoint for you all. I am going to go ahead and post it. It will be posted by this afternoon. There are some problems on there. If you do not know your ABGs, I meet with you on the 21st after Dr. Sayer lectures. We are going to be doing ABGs. We're going to talk about how they are compensated and not compensated and how you're going to figure them out. So I'm going to give it to you a week ahead of time. Normally don't do this, but I'm going to do this because you really need to know this. You need to start looking at your ABGs and you need to work through those problems that I put in the PowerPoint slide for you. Okay? Because when we come together, yes, you will work with them on the board. I'm a big board person, so when we come together that Monday, you will be doing them on the board. So let's talk about blood pressure in a stroke patient. What do you see in the blood pressure when a patient has a stroke? Hot. Very, very hot. The rule of thumb is that you don't bring those down quickly. Okay? You bring them down slowly. Because then you're just going to throw them into another shock if you bring them down quickly. It's just like diabetes. Blood sugar 600, you go bring them down to 200 in a couple hours? You better not. You're going to throw their body back into shocking, right? So they've already had a shock from having a stroke, so their blood pressure's already high, so you need to bring it down slowly. However, if you see a patient in the hospital and they've been there for 4 days and they had that stroke 6 days ago and the blood pressure's still 200 over 100, don't you think they should be on some type of medication before they go home? I would say so, right? So it's important that you start putting together your blood pressure, your diagnosis, and your medication. I've been working with that in my group on PCCU. Yesterday, they didn't, a couple of them did nothing but give medications all day, period, all day, because they had not had that experience before. So they gave meds all day. That allowed them to see the types of patients that were AFib, that were on Coumadin, AFib, amiodarone, right? That's AFib, metoprolol. Okay, gave them the chance to see those types of medications being used in the clinical setting and what they're used for. When somebody has a stroke, you expect them to be on medication before they go home. The reason I say this is on 7th South, there was a patient last semester, and the student gave medication but never really understood what was going on. The blood pressure was still extremely high. And they were going to discharge this patient with a blood pressure that high with no home medication for blood pressure. Okay. So I want you to start thinking about that. If you have a stroke patient or you have an elevated blood pressure, you need to start thinking about the types of medications that you're giving and how they work. Okay. What else would you expect somebody that has a stroke to go home on? How about our ABCs that we were just talking about? What was A?
Aspirin.
It can be something as simple as aspirin, a daily aspirin, right? Daily aspirin. Doesn't have to be a big old medication. It can be an 81 milligram aspirin that they need to go home on. Okay? So you need to be aware of those types of situations. And I'm not saying, in clinical, I'm not saying that, you would automatically catch that, but just think about it. Because when you become a nurse and you have your first stroke patient, when you're going to discharge them home, then you need to be looking at their medication. They were going to discharge this man with no medication. Well, but did the nurse do right? No.
You'd probably discharge first, but doesn't even know, but the nurse should catch it.
So that is my advice to you, is that you need to start looking at your meds, the diagnosis that you've got. When you get over to PCCU, it's a lot of heart meds, a lot of heart meds. Everyone that's over there on clinical with me right now can tell you that it is a lot of heart medications, a lot of blood thinners, a lot of heart medications, things that we've talked about. So when you have somebody who's on Coumadin, I expect you to know what their PTR is for the day, right? You should be looking at that. Right? Heparin, you need to know. When we get over to PCCU, you're going to see a lot of people with heparin drips. You need to know the protocol. You need to know platelet count. You need to know when it's too high, when it's too low, and what you need to do. Okay. All right. Any questions, concerns, or comments on intracranial regulation? Yes, it will be Saturday. You will meet me at 7 a.m. at Memorial's. Actually 6:45. I'll make you all meet me at 6:45. You will meet me at 6:45 Saturday morning at Memorial's